Good afternoon, everyone. I'm Barb Kabilis. I'm the Regional Stroke Education Coordinator for Central South Regional Stroke Network in Hamilton, Ontario. We don't have too many bonuses during the pandemic, but we are experiencing two today. I was able to bring Dr. Mary Warren to us from Kansas because she's able to present from there. And also because we're presenting virtually, we're able to open our presentation up today to the whole province. And I believe we have some people joining us from outside of the province as well. We had over 200 people registered for this webinar. And not all of you have joined yet, but we're expecting more as people come to the webinar in the next few minutes during their lunch hour. Thank you for joining us today. This is part of our 6-part series that we're presenting this fall on posterior circulation stroke. This is part 3. We have 3 more after today, 2 of them in November, 1 on vertigo and dizziness following posterior stroke, 1 on dysphagia, and then in December, we'll have 1 on ataxia. The first 2 presentations are archived on our website. I'd like to introduce now Dr. Mary Warren. Dr. Warren developed the graduate certificate in low vision rehab at the University of Alabama at Birmingham and served as its program director and as a co-director of the UAB Center for Low Vision Rehabilitation before retiring in 2018. She continues to teach in the certificate program as an adjunct professor. Dr. Warren lectures extensively on vision rehab for persons with vision impairment from adult acquired brain injury and is an internationally recognized authority in this area. Dr. Warren is the author of the Brain Injury Visual Assessment Battery for Adults, or the BIVABA, and regularly contributes to a chapter on evaluation and treatment of visual deficits following brain injury to the rehab textbook, Pedretti's Occupational Therapy Practice Skills for Physical Dysfunction. Dr. Warren is the 2019 recipient of the AOTA Award of Merit for her contributions in advancing the role of occupational therapy in vision rehabilitation. Welcome, Dr. Warren. We're happy to have you here today, and I look forward to many questions that people will pose in the Q&A, and I'll let you know when they come up. And I welcome you to start your presentation.
Okay, thank you, Barbara. Let's get started. I have a lot of information to cover today because this is actually a big topic. We're going to be talking about hemianopia, which is often a hidden impairment following post PCA stroke. And it really affects a person's function and their ability to recover from stroke. So I'm happy to be able to present the topic. So during this really brief little talk, I'm going to describe to you functional limitations that persons with hemianopia experience. We're going to talk about key behaviors that indicate that your client may have a hemianopia. We're going to talk really briefly about some screening assessments and identify some key intervention strategies. Now, the first thing I need to talk about is just vision impairment from acquired brain injury in general, because hemianopia is not the only vision impairment occurs. Hemianopia and other visual field deficits can occur, but the person can also experience a reduction in their high contrast acuity, which is directly affected to reading, and their low contrast acuity, which is your ability to see forms and things that don't have much contrast and very important for navigation. We can see a lot of changes in oculomotor impairment, and then we can see neglect. Now, when we talk about vision impairment, there are some primary behaviors that are associated with vision impairment regardless of the cause. So we'll see them in hemianopia, but we'll see them from other things. And the number one thing, and I'll emphasize this as we go along, is that the person doesn't have difficulty completing all of their ADLs, but they have difficulty completing vision-dependent activities. A vision-dependent activity is something like reading or driving, where vision is a critical component of it. And there's no way you can complete the activity without it. So all reading, all activities that require reading are going to be vision dependent. And a lot of IADLs will fall into this category. And I'll mention some of those changes that occur as we go along. But what doesn't fall into this category typically is the basic ADL. So if I put you in a darkened in closet, you know, no light coming into the closet, and I shove a plate of food in there after you, you're going to be able to eat. You might be messy, but you're going to be able to complete that activity. Same for if I lock you in a bathroom that doesn't have any lighting, you'll be able to toilet. But if I put you in that dark closet and I throw in your checkbook and ask you to, and your bills and ask you to pay them, you're not going to be able to complete that. So we have to remember it doesn't affect all ADLs. The other thing is that it slows processing speed. This is the #1 complaint of anybody who experiences a vision impairment, is that it slows them down in completing their daily activities. The challenge is that when we see slowness in responding to us in the context of a stroke or a brain injury, we often don't think about it being caused by vision. We think it is a cognitive issue. If you don't see well, you make a lot of errors in your decision making, and that makes you reluctant a lot of time to make decisions. You have to put a lot more effort into what you're doing, and that can cause you to get tired in trying to do things. And that all leads to kind of a dropping out of occupations, but especially the IADL. In general, persons with vision impairment, again, from any cause of acquired brain injury, are going to experience difficulty with activities that are completed in dynamic environments with lots of pattern. So these are the community environments where we do our driving and our shopping and our working and our sports. And the person is often, because they're so uncomfortable in these environments, kind of driven into the home environment, which is static, where they can control the pace of things. And they start to avoid participating in, they avoid getting out. That's what I want to say. They just don't get back out into the community. They kind of become a hostage to their home. And that can prolong their adjustment to disability, and it can impact their wellness. Now, the things that we need to consider when we're looking at a client who has vision impairment post-stroke is that that client is often older. And so they may show a combination of neural-related impairment, that which occurred from the stroke, but they may also be showing some impairment from a neurodegenerative disease. So if they have a co-impairment like Parkinson's disease or Alzheimer's dementia or multiple sclerosis, these three very common diseases all have a huge vision component to them. So we can see a combination of things. Also, when we're working with an older adult, we have to consider the fact that there are normal changes in vision occurring due to aging that reduce the person's ability to see contrast, increase the person's need to have lighting in their environment, and other things. So that's occurring in any adult that we're going to see over the age of 60. And then again, there are prevalent age-related eye disease, that's what ARED stands for, that can affect you as you get older. So we have age-related macular degeneration, which is the most common cause of low vision in Canada and in the United States. We have open-angle glaucoma, and we have diabetic retinopathy. So you're seeing a client for their brain injury, but they may be bringing all these co-impairments with them. The key thing that I want you to remember, and this is why it's in the title of this lecture, is that vision loss is a hidden impairment. We generally just observe only the consequences of vision impairment, and it mimics deficits in the performance skills that it supports. And we use our vision for motor, and we use our vision for cognitive processing, and we use our vision for social communication. So unlike a client who has hemiplegia or apraxia, which is very easy for us to observe, A client who has a vision impairment from stroke just looks like they looked before, for the most part. They just look like themselves. So this means that the client often presents an ambiguous picture to us on the rehab team, and it's difficult to tease out that visual impairment, particularly in the early stages of recovery. It may not actually be apparent until other skills like motor, cognitive, language have improved. That means that it's critical to collaborate with other professionals who are not always typically on a rehab team. So we have two types of eye doctors. We have the ophthalmologist, who is the medical doctor. We have the optometrist, who has a doctorate of optometry. And it's also important that all members of the rehab team communicate and work together. And for you all in Canada, that means including an orthoptist on your team. We don't have orthoptists in the United States generally, so we have to do without, but you have this valuable profession up there that can help you. Okay, so that's a little background. Now let's get a little more specific and talk about what I mean when I say a person has a visual field deficit. The visual field is the area of the visual world that you can see when you are looking straight ahead. So look out beyond your computer and your phone, and it's what you can take in. It's the brain's picture of what's going on in the world. And we divide it arbitrarily into right and left halves and superior and inferior halves. And when it's working well, when we have a complete visual field, we get a complete picture of the resources and threats. Visual field deficits occur from damage along the visual pathway and also within the occipital lobe. So you have seen these diagrams before when you were in school. The visual pathway is this long pathway that transects the brain. So it goes from one end of the brain to the other, starting with the retina, then the optic nerve, then the optic tract, into an important structure known as the logogenetic nucleus, over some huge tracts, and then taken into the occipital lobe. Because it crosses the brain, it's common to get visual field deficits. Any type of visual field deficit is common in adults and kids, and it can take different forms. It can be a hemianopia, it can be a quadranopia, it can be tunnel vision, it can be central field loss. Now, in stroke, damage occurs mostly behind the chiasm. So I've got my little arrow pointed on that chiasm. And that means that the person is going to experience the deficit in both eyes. So if you get ahead of the in front of the chiasm, just in the optic nerve and retina, one eye is affected. But when you get behind it, both eyes will always be affected. Okay, let's get even more specific and talk about homonymous hemianopia. Homonymous hemianopia is the most common form of visual field deficit that occurs following that PCA stroke. And what it does is it causes a loss of one half of the visual field in each eye. So hemi means half and anopia means blind. If we look over here in a printout of a perimetry test, we look up here and we have the normal visual fields on the top of this diagram, and they're nice and clean, light colored. And that means that the person whose visual fields these are, that person it can see everything, small details in the environment to big details. These little black areas here just mean that's where the blind spot is. But when we look at a hemianopia, and this is a right hemianopia, because field diagrams are always drawn as you see them. You don't have to do any reversing. We see this completely blackened in area on this side of the field, on the right side of the field, which indicates that the person can't see anything there, that part of your field can't detect anything. It's in both eyes, and it's pretty much the same deficit. So that's where the term homonymous comes from. Now, with PCA strokes particularly, you can get something called macular sparing. And macular sparing is an interesting field deficit because it presents as a hemianopia, Okay, so half of the field is involved, and we can see all the black down here. I'm on this lower diagram. But the macular part of the field, which is our reading part, and the part where our central field and where we identify objects, is not involved at all. These are people who are hard. They're really hard to determine what's going on with them, because they'll be able to read, they'll be able to pass tests that just involve dealing with details in front of them. But if you get them behind the wheel of a car, for example, on a driving eval, they will not be very safe. In terms of recovery, some improvement is possible within the first 1 to 3 months after the onset. And the percentages are going to vary depending on the study that was done, but about 40 to 60% of people with hemianopias experience some recovery of field, and they're more likely, that recovery is more likely for some reason to occur in the lower part of the visual field, which is good because we need that lower visual field for walking. But recovery slows down with time. So there's generally little recovery beyond 4 to 6 months. And for most people, visual field deficits are permanent. There'll be some residual deficit that will not improve over time. Medicare, which is our primary payer in the United States, for this reason considers visual field deficits to be a low vision condition. Hemianopia is classified as low vision in the US, and I think probably in Canada too. Okay, so that's a little background. I want to spend most of my time on the functional limitations that we see so that you'll be able to recognize behaviors that suggest that a client has a field deficit, and you'll be keyed into the ADLs that they're going to have difficulty completing. The primary challenge with a visual field deficit, and this one is kind of abstract, and I need to spend a little bit of time on it, but the primary challenge for this person is that they do not perceive the loss of the visual field. Whoops, got ahead of myself. Instead, even if you've lost half of your vision, which is what occurs in a hemianopia, when a person who is experiencing a hemianopia wakes up, after their stroke and starts to look at their world, they perceive an unaltered and complete visual field. There's no black curtain indicating blindness in one side. There are no gaps in the field. So there's nothing to tip them off to the fact that they have lost vision. It occurs because of a normal perceptual process that is driven by the frontal lobes called perceptual completion. This is a cognitive process that uses memory and prediction in order to create the visual scene for us. And the visual field does this by predicting what will be seen based on experience, instructions, and expectation. So why do we need perceptual completion? We need perceptual completion because we are taking in a lot of visual information at all times. If I were teaching you in a live course and you were 200 people sitting in front of me in an auditorium, if the only way I could construct the sense that you all were there is to train my fovea, my central vision, on each one of you so that I could foveate you and identify you, it'd take me forever to do. So we can't survive. We cannot do that kind of individual, I'm going to look at this target and then this target and then this target to build a visual scene. Instead, what the frontal lobes do over time, based on your experience, based on the instructions that you're given and based on the expectation, is that they will just sample the visual field and then complete it. Okay? So let me give you an example of this. Let's look at this diagram over here on the right side. What I want you to find is this solid white triangle. So I'll give you a second to do that. Okay, so the solid white triangle is right here, right? Plain as the nose on your face. But if you really look, there is no solid white triangle there. It's an absence of space. It's not a presence of an object. But I said there was going to be one. So I gave you instructions to find it. I told you you would see it based on your experience with triangles. What you did, what your frontal lobes did, is I looked at these little Pac-Man figures and these little angles here. And they said, well, okay, if there's a solid white triangle here, it's right in the center. That's an example of perceptual completion. One of the challenges with perceptual completion is that it influences, very significantly influences, safe navigation, which is one of the big issues that persons with hemianopia have. So I'm going to give you another example. This is a sidewalk leading down to the street, okay? And up here, where we can't see, is a house. And in this house lives a little man. And he had a posterior cerebral artery stroke, and he developed a left hemianopia from it. And he is going to take a daily walk today because his doctor told him to walk every day. So he's coming down his sidewalk to connect with the sidewalk that goes in front of his house. And his right visual field is picking up all of this information over here. I'm moving my arrow back and forth, okay? So that's what he is mapping and seeing at this time. Okay, takes off, starts walking down the street. While he's gone, unbeknownst to him, his granddaughter comes over to see everybody, and she rides her bike over and she dumps her bike on the sidewalk and runs inside the house. Now our gentleman is coming back from his walk. He did not anticipate that his granddaughter would ride her bike over and dump the bike on the sidewalk. So as he's coming back up the sidewalk, he's using his memory of what he saw when he walked the sidewalk to begin with, and he sees a clear path as he's going back to his house. But in fact, the bike is there. So he collides with the bike. That's the way you learn about a visual field deficit when you develop it, is you learn about it through interaction with your environment. Perceptual completion then alters how a person starts to search their environment. The client, because there is no uninterrupted visual scene, they have difficulty knowing where the border of the blind field begins or ends. There's no marker indicating the transition between the seen and non-seen field. That's a scary situation to be in. It causes those collisions that we talked about. So to compensate, clients will do different things. They may adopt a very narrow search pattern that they can find to the midline directly in front of them and over to the sound side, where they know that they're getting information that they can trust. When they adopt that behavior, they often look like they're neglecting one side more than the other. And so our minds, if we don't understand vision impairment, can go down the neglect rabbit hole. When they are forced to search the blind field, when they need to find a target there, because they can't tell when they get into the blind field or where the target is located, they will employ a stair-step saccade to locate targets. So they move their eye a little bit into their blind field, no target. They'll move it a little bit more, no target, and keep doing that until they finally find the target. That can really slow down visual search and slow it down to a point where you cannot adapt in a dynamic environment. The other thing we need to remember about perceptual completion is it reduces the person's sense of self-efficacy and their autonomy. The person first experiencing visual field deficit instinctively will trust their newly altered perception that they're seeing a completed visual field. And as a result, they're going to experience mistakes and collisions, as what happened to our little man who was taking a walk. So some common examples that can occur is like a person might be in a grocery store and they think the aisle is clear in the grocery store, and they start to walk down the aisle and collide with another shopper or a pallet or a box or something like that. Or they think they've read to the end of a line of text, and then they realize that, well, this text isn't making any sense. I can't figure out what it is because I didn't get to one side or the other of the text. This disconnect between perception and reality will cause the person often to be confused and be uncertain. They'll get a lot of anxiety, they'll get fear because they don't know how to interact with their environment. They will lose their self-confidence, their sense of self-efficacy, and that will cause them a lot of times to become much more passive and reliant on others for decision-making, for directing their actions, for completing activities. Again, when we see a client who is passive and wants others to give direction and lead them through an activity, we often, when we see that in the context of brain injury, we often say, well, that's frontal. That's a frontal part. The frontal lobes are not working so well. But the person, because they're getting so much anxiety and fear in doing activities, particularly those in a dynamic environment again, will drop out occupations, which is a theme in this talk. So let's talk now about more specific changes. I'm trying to go from kind of broad to more specific as we go through the talk. Hemianopia causes challenges with navigation. We see changes in both mobility and orientation. It changes reading. It affects writing and other activities that require eye-hand coordination and activities that require eye-foot coordination. It affects the ability to complete that vision-dependent ADL, and it causes a narrowing of occupational engagement. Let's talk about mobility first. A person who is experiencing a visual field deficit learns pretty quickly that what they have to do in order to stay upright is they have to allocate their attention to the support surface. So they often walk very slowly initially. They have kind of a stiff, uncertain gait. They come very close to obstacles or they collide with obstacles. If they're faced with an uncertain kind of subtle feature like a curb cut or a wheelchair ramp or something like that, they have difficulty figuring out what that is. But some of the key behaviors that we see related to that is that they will tend to shoegaze when they have to make transitions. They may trail where they bring their hand out and feel their way along a hallway or around a piece of furniture. If they're having to try to find something as they walk, they may do exactly what they do when they're scanning. They may walk a little bit, stop, search to see where they are, then walk a little bit more, stop, search to see where they are, and they will follow people. The following can be a very subtle thing where they just, if you ever walk with a person with a hemianopia or a pretty significant field deficit, they'll get slightly behind you. They don't walk in front of you and they don't walk right next to you. They get a little bit behind. They lag behind because they're using you to direct them. I have some nice videotape of a lady named Ida who experienced a right hemianopia from a PCA lesion. She's going to walk down a hallway to our therapy clinic. This is her second day of therapy. She had evaluation on the first day. She's starting treatment. And she's 78 years old. I want you just to watch her walk. Man is giving her directions.
Yeah. Is there any more around here?
Is it pull or push in?
We got to turn it.
It's a lever handle. And you'll notice as she walks through the door, she puts her head down to see the floor because she's transitioning into a new environment. She doesn't look very confident when she's walking. She has that stiff, uncertain gait. She has been to the clinic before. She knows she's going to go through a closed door. But when she gets there, she did not see ahead that lever type handle on the door. So she didn't know how to place her hand on the door to open it. This kind of mobility challenge where a person feels glued to the support surface so they don't injure themselves, they have to allocate all their attention there, doesn't necessarily save them because they don't pick up objects that are appearing on the sides of them. So 90% of them will have reported experiencing a collision at one point in time, which causes them to anchor even more. That's from a study that I did in 2009. And 44% of them report a fear of falling. That really changes how they're able to move about the environment. Now, the other side of navigation is orientation. And when a person who has a hemianopia is walking, they don't obtain enough visual input to build a complete and accurate map of the surrounding space. That need to focus on staying upright will limit their awareness of their surroundings. And then perceptual completion is also working here because it slows their search when they don't know when they're getting into the blind field. So they're unable to scan fast enough to build the visual scene. What happens is a person experiences a tendency to get lost. They may not actually get lost, but they feel like they're going to get lost. And it makes them very anxious and very uncomfortable navigating by themselves. So the other behavior that we see is they avoid independent travel. They rely on other people to lead them. And that can be difficult for the client and the family. I want you to think back to when you were almost ready to drive. You almost were old enough to get a driver's license, but you weren't there yet. And think about the family dynamics at that time. You are sick of having to ask somebody to take you someplace. And your mom is sick of having to drop everything and take you, your dad. It's difficult for the client to be in this dependent position, but it's also difficult for the family. It puts a lot of pressure on them when they have a member of their family who cannot navigate independently and assist with things. Okay, another big area that can be affected by both right and left hemianopia is reading. And reading can be a topic into itself in a lecture. So I'm just going to kind of touch on it. The key to understanding how hemianopia affects reading is to understand that our fluent reading depends on a normal perceptual span, using a normal perceptual span to view text. So what is the perceptual span? The perceptual span is a little window right at the fovea that is approximately 15 to 19 characters wide. It's asymmetrical in those of us who read left to right. It extends farther to the right, almost up to 15 characters, than it does to the left, about 3 to 4 characters. So it extends farther to the right on fixation and less on the left side on fixation. I tried to illustrate it down here as best I can. This is the perceptual span. Okay. The foveal area, the light blue area, is the area where you can see small detail very clearly. So we use this little box to decode words. The parafoveal area, this darker blue area, it helps guide our saccades across a line of text so that we can move through our reading text. We can't really detect the letters so much and decode them as well as we can see that there are 6 letters here and there are more letters over here and that type of thing. When we read, we alternately fixate and saccade through text in order to move this little window across the text that we're reading. And we move from the middle of one word to the middle of the next word. And each side of the perceptual span plays a different job. The right side of the span will partially decode the next word or words, and it will also plan the next saccade so that we land in the middle of the next word. So let's look at the right side here for a second. The person viewing this text is going to see the word without very clearly, and they're going to see the next few letters. And so the right side of the perceptual span is going to decode the word for you, but it's also going to start to decode the next word, children, so that you can read very quickly. While it's doing that, it's also planning your next saccade so that you're going to go from the word without to the word children. You know, I said we're going to go from the middle of one word to the middle of the next. The left side of the perceptual span is really involved mostly in word recognition, but it has a big job in navigating that left word saccade we make in order to start the next line of text. So it's what keeps you going from line to line to line as you go through text. What happens with hemianopia, again, either a right or left hemianopia, is that it will shorten the width of the span on the hemianopic side. So depending on whether it's on the right or left side, it's going to cut off letters at the beginning or endings of words, and it will cause misidentifications to occur. So you may be looking at the word snow, but you see it as the word now. Or you may be looking at the word hanger, but you see the word hang instead. So it reduces your fluency in reading. This smaller window also significantly disrupts the saccade pattern where you're going from the middle of one word to the middle of the next word to the middle of the next word across the text. So it's going to be a big issue with right hemianopia because the right side of the span is what helps you make that saccade. To compensate for it or to get through text, persons with right hemianopia often use kind of hit and miss saccade patterns to locate the next word and move through text. It's not a controlled movement. They sometimes skip over small words or they don't see all of a word. You know, it's just a very random way where they're trying to power their way through the text. Persons with left hemianopia will often undershoot the saccade that helps you locate the beginning of the next line. And so they often omit words on the left side of the page, or they may skip a line of text as they're reading. What happens in either case, right or left hemianopia, is that the person is forced to make a regression in order to accurately read text. So regression is when you go back. You're reading along and you're going, that didn't make any sense. And you move back and reread it. I think the best way you can think of regressions is when you were in school and you were reading a neuroanatomy textbook or neurology textbook for the first time, and every other word didn't make sense. So you were doing a lot of regression when you read. And you know, when you're regressing a lot, when you're having to reread a lot, it's going to reduce your reading speed significantly. So it reduces reading speed and it reduces accurately, but the biggest effect typically is on speed. Persons with hemianopia read at about 50% the rate of persons without, so 50% of normal reading speed. Plus, when you're doing all this regression, you have to put a lot more cognitive effort into reading. Again, think about reading that neuroanatomy text. Was that a fun experience for you, or was that something you just had to force yourself through? And when you have to put a lot of effort into reading, you don't enjoy it. It reduces your pleasure in reading. It reduces your confidence that you are reading accurately. And so persons with hemianopia will often say that they feel that they can no longer read. It's not a language issue. It's not an acuity issue in terms of being able to see text. It's that what they're really telling you is they're putting so much effort into reading that it's just not worth it for them. They don't feel like they can do it. Now, we can also see changes in eye-hand and eye-foot coordination. This occurs in kind of a specific, you have to have kind of a specific loss to have this occur. You have to have your hemianopia on the same side as your dominant hand or your dominant foot. So if that happens, so I'm left-handed, if I have a left hemianopia and it comes all the way into my fovea and I'm left-handed, it's going to reduce my handwriting legibility. That's usually the most obvious thing that we see. The person may drift up and down on line. They may write on top of other words. They position incorrectly on a form. I have a little picture of this. This was a gal with a right hemianopia. And when she was trying to address an envelope, she had this really downward slope to that. So right-handed with the right hemianopia. You can have difficulty completing activities that require precision and visual guidance of the hand, like pouring or cutting or keyboarding or using your smartphone to do things, because again, you're not monitoring your hand well. And you can have difficulty completing activities that require precision and visual guidance of the foot. So sports activities come to mind, but also just being able to walk on a very cluttered, uneven terrain requires that we visually guide the foot more. And so that can be problematic for you. Climbing a ladder is another example I like to use, or stepping down from something, because you lack that precision. And of course, that is going to make those activities more stressful for you and also more dangerous for you. Okay, we've talked about this once, so let me just mention it briefly, but the challenge that happens is difficulty completing the vision-dependent ADL. So there's been a lot of research that has listed out the specific ADLs that persons with hemianopia have. They have difficulty with reading-dependent activities, financial management, meal preparation, any kind of communication on a smartphone or a computer. They have difficulty with activities that require that they monitor and use a wide visual field. So meal preparation, which also involves eye-hand coordination, cleaning, yard work, particularly if your yard work involves a lawnmower or working in a garden, viewing sports, viewing movies, and then the activities that occur in dynamic environments like driving, shopping out, dining, and recreation. Okay. That should give you a pretty good idea of the challenges that your client is going to face in doing this, doing their daily activities. So let's talk a little bit about evaluation, and then we'll move on to intervention and hopefully have some time to answer some questions. First thing on evaluation is, why is it important? Why do you need to screen for visual field deficit in your client? Well, number one, for PCA stroke, it commonly occurs. It's a common occurrence following PCA strokes because PCA strokes affect the occipital lobe. But also, when it's there, it can reduce the ability of the person to achieve their other goals. Zill, an early and prominent researcher in this area, did a study way back in 1995, where he showed that just having a hemianopia is going to reduce the likelihood of achieving independence in ambulation and ADLs by 20%. The other thing that we have to know about evaluation is that it's difficult to accurately assess the visual field early in a person's recovery from brain injury. And this is because of the demand of the perimetry test. So perimetry tests are the way we measure the visual field, and all perimetry tests, it doesn't matter which one you're using, have three components that are required of the person. They have to sustain fixation on a central target. While they're sustaining the fixation on that central target, there will be a second target of a specified size or brightness that appears in the field. And without breaking fixation, they have to acknowledge the second target appeared. So all perimetry tests have a high demand on the person's ability to attend. And that's why it's difficult to assess them early in recovery, is because you got to be able to attend and follow directions to avoid cheating on the test. If you cheat on the test isn't going to be reliable. Diagnostic evaluation, where we actually can say, here's the deficit, this is what it looks like, needs to be completed by an ophthalmologist or an optometrist. because the assessment tools that are used for diagnosis are expensive little tools like the Humphrey Visual Field Analyzer. And when we're screening for field deficit, we may screen, possibly on the best test up to about 20 or maybe 30 points in the visual field. We'll have the client will test those areas, where these diagnostic assessments assess 125 and more than that as you go through. So to get the really definitive statement that this person has a field deficit and this is what it looks like, you have to refer them. Somebody has access to these screeners like the Humphrey Visual Field Analyzer, and that's the optometrist and the ophthalmologist. Bruce did an interesting study in 2006 where he found that for clients who have multiple impairment from acquired brain injury, the median time it took to be able to complete a diagnostic test was 5 months because of the demand on the attentional system. For example, a client who is completing a field test to check for hemianopia on the Humphrey Visual Field Analyzer will often have to attend for 30 minutes in each eye. So the test will take an hour, 30 minutes to test each eye. It's a real challenge for the person. Persons with PCA stroke, because they have subtle impairments, but a lot of times they can attend pretty well. They can often be tested earlier. And so working in our low vision clinic, for example, we saw a lot of persons with PCA stroke not very long after their stroke because they could be tested earlier. So it depends on when this test can be done. What that means for us is that if we have this client in the very early stages of recovery, the best way for us to try to determine if they have a field deficit is to observe for behaviors that suggest the hemianopia is there. We can't rely on the client to provide an accurate description of vision loss because of perceptual completion, but the team should see consistencies in behavior. So the PT should see, if it's a left hemianopia, the PT should see some challenges in moving into left space and the changes in mobility. OT should see the same kinds of challenges in ADL, etc. Key behaviors that we want to look for are that the client misses objects and features located on the blind side, especially smaller pattern objects that lack contrast. So the things that are more difficult to see. But they attend and search that side when cued. This is a key part of this. So if they are looking at a tray of food and they miss the pudding cup that's on the right side, if you tell them it's there, the pudding's on the right side, why don't you find it and eat it, they will attend and search that right side because this is a primary sensory deficit, not necessarily a problem with attention. They come close to or collide with or knocks over objects on one side. They have difficulty reading, but they are aware of their mistakes. They know that things are not making sense when they read. They're anxious and stressed in crowded, dynamic environments. So they don't like coming into the gym and moving around the gym, but they can do better up in their room. Okay, one screening assessment that I wanted to talk about because it's so widely used is the Confrontation Test. You all probably know some form of it where the examiner confronts the person's visual field by holding up two targets, often their fingers. And the person is supposed to fixate on their nose and then tell you, how many fingers am I holding up? This is a test that's used a lot, but it really is not a reliable test at all. It's got a lot of problems with it. Number one, you're estimating how much field is missing by comparing it to your own visual field. So we have to make the assumption that you have a normal field. Number two, your face is the fixation target. So you need to be comfortable with the person looking at your face, and you need to be able to visually monitor them looking at your face at the same time where you're moving targets. So it's a very divided attention task for the person who is giving it to the client. And we often give the client lots of cues as to where we're placing our fingers and that type of thing. As a result, it can greatly underestimate the presence of a visual field deficit. Trobe, way back in 1981, took a look at this test and said it's no better than chance. So it should never be used as a diagnostic type test. It's just a very gross screening. So attention is the issue, again, when we're screening for visual field. We need the client to stay fixated on that central target. I wanted to show you an alternative confrontation test that helps control for this. This is called the two-person kinetic test. It's from the Brain Injury Visual Assessment Battery for Adults. I'm going to show you a clip of how it's administered, and then I'll talk about it for a second.
Now for this test, we're going to need two people to do the test, two examiners. So my father-in-law Gregory is going to play the role of the second examiner. And what he's going to do is he's going to hold this card up in front of you. This is the flower. And what I want you to do is to always be focusing on the flower. So he'll hold it up. You keep looking at it. It's very important that you keep your eye focused on it. What I'm going to do is I'm going to take this little pen light, a little bright light, and I'm going to bring it around from behind you. As soon as you notice the light from the pen light, I want you to say now. Okay?
All right.
But the very important thing is that you keep focusing on this flower. Don't pay attention to me. Focus on the flower. When you see the light, just say now.
Okay.
We're going to turn down the lights. Now, your job, Gregory, during this, because I'm going to be standing behind her, it's going to be difficult for me to know this. Your job, besides just holding the target, the flower, is to make sure that she keeps her eye on the target at all times. If she isn't, if when I move the pen light or get behind her and start to move the pen light, she's moving her eye all around searching for it, you have to tell me that, because we call that cheating on this test, and we have to do it again. Now, when she notices the pen light, it'll be just a reflex for her to look towards it, and that's okay if she does that. But what I don't want her to do is to be constantly looking around while I'm just starting to move the pen light. We're going to lower the light so that the pen light's a little brighter. All right, you're looking at the target, Jean?
Yes.
Okay. Just tell me when you see the pen light.
Okay. Now.
Good. Yeah, that's good. Okay. Just keep looking at the flower again. Is she looking at the flower, Gregory?
Yes.
Okay, keep your eye on it. Tell me when you notice the pen light.
Now.
Okay. Looking at that flower?
Yes, ma'am.
Okay, just tell me when you notice the pen light.
Now.
Flower?
Yes, ma'am.
Okay, keep looking at the flower. You're still looking at the flower? Is she looking
Yes.
at the flower? Okay, tell me when you see the pen
Now.
light. Okay.
Okay, so this is still a very gross assessment of the visual field. It's just going to give you a sense of it. But the use of the second examiner reduces cheating. The fact that I prep her every time, are you sure you're looking at the target? Is she looking at the target? That type of thing keeps emphasizing the importance of staying on that central target, helps to reduce cheating. Using a bright pen light is also important because I'm coming from behind her and I'm going to contact rod cells first in her visual field. Rod cells don't see color and they don't see form. They see light and they see movement. So the bright pen light target close to the face reduces the false positives when doing a test where you're coming from behind the client.
Now for this.
Okay, another assessment that I wanted to alert you to is called the SCAN course. This is also from the BIVABA. It's a dual task assessment that looks at the ability of the person to integrate visual search with ambulation. So I'm gonna show you a videotape of it first. What we do in the scan courses is we take little 3x5 cards, index cards, and we put a single stick-on, 1-inch stick-on black letter. Okay, so you can kind of see a little card there. It's probably the most visible. You can see one sort of here. And what we ask them to do then is walk down a hallway and point out these letters or numbers as they go down the hallway. So let me show it to you.
On this test, Jean, we're going to see how well you can scan when you walk. Okay? And I'm going to be showing you, I'm going to have you look at cards that look like this. And so we'll show the camera. It's just a 3x5 note card that has 1-inch stick-on letters on it. And if you turn around and look, you'll see that there are cards all the way down the hallway. So as you walk down the hallway, you'll be turning your head back and forth and reading out the number to me as you go.
6, 3, 2, 7, 8, 9, 8, 0, 9.
Okay, you did a good job going through it the first time. You saw all the numbers on the wall. We can give you a second chance now, a second trial. We're just going to turn around and go down the hallway again. The instructions stay the same. You'll just be reading the numbers out as you walk down the hallway.
Put 3, 4, 4, 5.
Okay, so it's a very simple thing. You put the cards along the wall, 10 on each side. You have the person walk through, identify them. When they go through the course one direction, and then you give them feedback, and then you have them reverse course through to see if they can pick up from your cue and use their attention to improve their performance. When we're looking at a good compensatory strategy, their head's going to be up and they're going to be locating the targets without pausing while they walk, which is what we see Jean doing. A poor compensatory strategy is where they fixate on the floor, stare straight ahead, or stop to try to locate the targets. It was recently validated by our good friends in Canada who established its validity as an assessment and established good iterator and retest reliability for that. That's Lund down there and Chow. The advantage of this test is that it is inexpensive and it's flexible to do, and it can be set up anywhere. Now, when I initially put it, it's part of the BIVABA. When I initially put it in there, I just wanted it to be used as sort of an observational thing. And so I left a lot of leeway on it. But when Lund wanted to study it, when that group wanted to study it, they needed to standardize where they placed the target. So they did that. They created a standardization manual for how they did the tests. And I put that link or that contact information in your handouts because they're willing to share their manual with you. Whiteboards can also be very helpful when we're looking at clients and trying to determine how they respond to their visual field. Whiteboards are primarily intervention tools, but they're always recording data as the person goes through the activities. So they let us know speed and they let us know accuracy as the person goes through. They also, because they're big by nature, they help provide an opportunity for us to observe slow scanning and processing on the blind side. And they give us a chance to compare performance between fields. So there are a number of them. We have the Dynavision, which was the only one for a long time. It has subsequently, the company has gone out of business, but there are a lot of Dynavisions out there. We have Vision Coach, which is a kind of a variation on a Dynavision. It came after it, and it's got Dynavision has a lot of depth to it, but the Vision Coach doesn't. We have the BioNest Integrated Therapy System, which is an interactive touchboard that plays a lot of different games. It's marvelous, but it's expensive. And then, because some of you may be aware of it, there's something called the NVT Vision Rehabilitation System. It came out of Australia, and it's a long, narrow strip. But all of these are involving touch and find type activities with the board recording the information. Okay, moving on to reading. There is one good test for the speech pathologists out there, or the OTs, that has been validated on persons with hemianopia and will look at the effect of the visual field deficit on reading accuracy and reading speed. It is called the Pepper Visual Skills for Reading Test. And it was developed initially for persons who had macular degeneration, looking at the influence of a central scotoma. Sarah Blaylock, one of my doctoral students, validated it on persons with hemianopia in 2016, because it really is a good test for a person with a hemianopia, because they do essentially have a central scotoma in their vision. But anyway, I won't digress. It consists of these kind of big cardboard test sheets, test cards, that's the word I want, where they start out with just single letters, okay? And then the letters start to mix in with short words, and everything is triple spaced up here. And then as you come down, it becomes just words, and the words get closer and closer together. The pepper test is peppered with words that can be misread if you don't see the entire word. So like here is the word black, and you could read it as lack. And here's the word dependable, and you could read it as depend. So it picks up on those types of mistakes when you're reading. You hand the card to the person, they read through it, you score them on a form like this. And from that, you calculate the percentage, their accuracy in reading, and how many words per minute they were reading on it. The circles on this test, this was a person with the left hemianopia. We have all these omissions on the left side of the test card because she couldn't get all the way over to the left side to read them. This is the word spiteful, she read it as pitiful. This is the word stop, she read it as top. So you can kind of see how it works. It's a great test. Okay. I want to mention, before I move on from reading, that it's very important that we look at numbers, because persons who have hemianopia don't just have difficulty with reading words, they have difficulty accurately reading numbers, particularly numbers that occur in a sequence. So numbers have similar configurations, 3, 6, 8, 5, 9. So they can be easily misread if you don't see them completely. But the challenge when we're dealing with numeracy, when we're dealing with numbers, is that there's no delayed feedback, when mistakes occur. So when you're reading something, you can say, oh, this just doesn't make sense to me. You're getting that feedback when you're reading words. But when you're doing numbers, it's like, is the Visa bill $688 or is it $633? Well, if you make a mistake, you're going to find out 4 weeks later or whatever, when you get the statement from your credit card company that you paid the bill wrong. Or is the expiration date 3/6/2021 or 9/5/2021? And again, you get the feedback later when the medication isn't working or the food is making you sick. The common errors that are made are incorrectly identifying the number. And so persons with hemianopia tend to use a finger strategy to help guide them through copying down numbers specifically. I have 2 different clients, both of them posterior PCA stroke, sorry. One is Ida, who we have seen before, and I'm going to show you her strategy in doing what's called the telephone number copy. What I want you to look at is how she uses her thumb on her left hand to keep her in place. Okay, so in the interest of time, I'll stop that one. I'm trying to stop it. There we go. Now, I want you to look at the bottom video. This is Gloria. Gloria also had a PCA stroke, but she's about at least 10 years younger than Ida, but she uses the same strategy. We see that kind of strategy in persons with right hemianopia a lot as they try to navigate, sometimes through text, but a lot of times when they're just trying to be sure they're reading numbers accurately. Okay, in terms of assessing for activities of daily living, there is a ADL assessment that looks at vision-dependent ADLs. It's called the Self-Report Assessment of Functional Visual Performance, or the SAFREP. It's a 38-item assessment that only looks at vision-dependent ADLs, and another one of my graduate students validated it on persons with hemianopia in 2012. We make that freely available. That assessment is freely available through the University of Alabama at Birmingham OT program at this link. And I put this link in your notes as well. So if you're looking for an assessment, there it is. Okay, one last thing that I need to mention on assessment before we go into intervention is that we need to distinguish hemianopia from neglect. Neglect is much more common following a middle cerebral artery stroke, but it does occur with the PCA stroke. And so what we need to remember is that hemianopia is a primary sensory deficit. It causes blindness in the field. It limits the amount of incoming visual information, but it does not alter the ability to attend. Neglect is a cognitive deficit. It alters the ability to attend to visual information, and that reduces the ability to acquire sufficient information to complete an occupation. It can be accompanied by a left hemianopia, and that really makes it extreme when that happens. But we have to remember that it's altering attention where hemianopia is altering vision. The best way to distinguish between these two conditions is to do a cancellation test. Cancellation tests came into the research in the 1970s when Diller and Weinberg and their research group at New York University determined that persons who had neglect changed the way they search, had specific search patterns when they were doing cancellation tests. So these are just different cancellation tests that you may have seen. This is from the BIVABA. This is the star cancellation test from the BIT. This is the Bell's test. But all cancellation tests require that the person go through looking for a specific target. In this case, it's the PNF. In this case, it's the stars, the small stars. In this case, it's looking for the bell. And the person has to work their way through the cancellation test and find everything. We did some research just looking at how adults without brain injury do on the subtests of the BIVABA. And what we found, and other researchers have found similar things, is that if you don't have anything affecting your vision or your ability to attend, you're going to use a left to right, top to bottom linear strategy most of the time, particularly if you're looking at something that's letters. And you'll be symmetrical, consistent, and accurate when you're doing it. What I wanted to show you, though, was the difference between hemianopia, a person with hemianopia completing this test, and persons with neglect completing this test. So both left hemianopia and neglect are going to cause or can cause an abbreviated search pattern with omissions on the blind side. But the difference occurs in how the person searches, that search pattern. For persons with hemianopia, the pattern is often slow and tedious, but it is organized. For persons with neglect, the pattern is often asymmetrical, confined to one side. Their approach is very random and disorganized. Persons with hemianopia hang in there. Their ability to sustain attention as measured by time is appropriate for the task, where lots of times with neglect, fatigue happens and we get short completion times, little or no rescanning to check accuracy. Persons with hemianopia, when you cue them to look for targets on the side of their vision loss, they often will go find them. Where persons with neglect can't incorporate the cue, and there's less improvement with practice. So these are two clients. They're both doing the word search where they're crossing out the the and the at. This is from the BIVABA. Let's look at Gloria first. We had seen her previously. And you'll notice that she's got her finger strategy going for her. But she's very carefully going across the line, the letter strings, in order to find the words. Okay. Let's stop her. Whoa, sorry. This doesn't navigate very well. Okay, now I want to show you Julia, who does have a left hemianopia, but she also has a pretty good case of left neglect. Same test.
Okay, again, there are 7 rows of letters here. This time, I want you to look through the rows and find the word the or at. Okay? Again, when you're done, put your pen down.
The at.
Yeah. Are you ready? Go.
I'm not sure how to spell it. The T-H-O-W.
Here at the top here, there's an example of how it's spelled.
I see ad.
To the left.
Oh, T-H-E. Oh,
Yes.
okay, thee. I pronounce it thee. Okay. T-H-E right here, thee. Oh, this is harder than what you think it is. With crazy eyes.
There's more to the left. Take a look over here.
There's that. T-H-E. That was backwards, I think, but it's still the same thing.
When you're done, you can put your pen down.
So she very quickly puts her pen down because that was a real struggle for her to be able to find the targets. All right, let's move on to intervention as we're closing out this very quick session. It's important to remember that hemianopia creates a permanent deficit. So the client has to learn to use their remaining vision to compensate for that vision loss. And the key interventions that we do to help them learn to compensate by using the vision they have remaining, key intervention is compensatory visual scanning training, which I'll talk about in a second. But assistive technology and adaptive devices can also help the person compensate. So it's an important aspect of the intervention. The other thing is that environment strongly influences the client's performance. This is true regardless of any type of vision impairment you have. You're very dependent on your environment. And environments and tasks often contain a lot of visual stressors that increase effort and reduce success and cause a lot of fatigue in the client. A client who feels a lot of visual stress from the environment is going to be less motivated to participate, and it's going to ultimately drop or avoid that activity. So another key intervention is to create a visible, structured environment and tasks to get an optimal person-environment fit and facilitate visual search and reduce visual stress. Now, before you even start intervention, you need to maximize the client's ability to use their current vision. And what I mean by that is that you need to make sure that the client has and wears clean eyeglasses. You need to ask, Do you wear eyeglasses? What do you wear them for? Where are they? When was the last time they were updated? Those types of questions need to be done. There have been a few studies done looking at this, but I like the lottery study a lot that was done in 2000 because they looked at persons admitted to a rehab floor. And what they found was that 25% of those people coming in onto the rehab floor didn't have their glasses with them. And I don't think that surprises anybody. And those who had their glasses, 27% of those glasses were dirty, scratched, or broken or outdated. So my recommendation to you is ask those questions, keep glass cleaner in your pocket, use it daily with your clients, educate other rehab team members to do the same thing. Also, if the client has not seen an eye doctor for a while and you suspect that the glasses are outdated just by looking at them, you need to refer the client on to the eye doctor. 50% of the participants who wore glasses in the lottery study benefited from an updated refraction. It is amazing what the eye doctors can do to just improve vision by doing a careful refraction of the client. These are typical visual stressors, and I tried to deliberately kind of pick pictures that are hospital-based. So this is low contrast. I don't think you'd argue with me on that. Everything is white. Okay, this is trickier. This is a hallway that connects two parts of a medical complex together. And during the day, at certain times of the day, you can get a lot of reflection on the ground, shadow and that type of thing from the light coming in the windows. And it causes a deceptive pattern, floods the area with light. So sometimes it has too much light, sometimes it has too little. And then all you got to help you through it is this very low contrast, not very obvious handrail. This is a client inpatient room. We've seen these all the time, and it's low contrast in general. If you look around, there's not a lot of contrast between anything. But one of the problematic parts of this room is this big window. That window is going to cause a varying light level where it can be flooded with light at some times, and the person may experience so much glare and light that they can't see well. And then when nightfall comes, they're left with this terrible lighting that's provided by the hospital, this awful fluorescent stuff that doesn't give them enough light to be able to see anything. This is a call button down here that matches the color of the sheets. This is a client's home. I wanted to throw one in there for you guys who do home health. She did all of her medication management and her bill paying in her dining room, which had dark walnut paneling and this old-timey combination of fan light above that was giving very little light into anything. She did have a window that could help her in the early morning see things, but at night she couldn't see anything. So we've got too little light. We've got a lot of clutter and pattern there without any kind of structure. And then I just saved this one for last. This is the interior of an assisted living facility, and it's just got a little bit of everything. It's got glare, it's got low contrast handrail, it's got a lot of pattern coming across on it. So these are difficult environments for people to adapt to. So the first thing in an intervention is to reduce the visual stressors and create a visible task and environment. It's always a three-step intervention where we add sufficient, well-tolerated light. Brighter lighting increases that visibility of small, low contrast features. Then we increase the contrast of key features in the environment to make them stand out and more easily identifiable. And then we reduce the pattern in the environment and in the task, because pattern camouflages features and objects and hides them from the client. Pattern can be inlaid like a plaid couch. It can be overlaid like shadow coming over an area, or it can be just clutter like we just saw. Adding optimal light. In terms of lighting, we want even illumination, no shadow. We want maximum illumination, and we want minimum glare. And halogen and LED lighting provides the strongest illumination with the least amount of glare. We also want flexible placement so we can get a light source as close to a task as possible. So that's where task lamps become an important part of what we provide. This is a halogen one, this is LED. And in the hospital setting, there are a lot of really nice battery operated LED lights that can be used to help our persons in their poorly lit rooms at night to do their activities. We also want to add contrast to key features and items. So looking at this placemat up here on the upper left side, white place, white plate, white placemat, not very visible. We can make it much more visible by putting that plate on a black background and giving a solid color napkin and a solid color cup. Here's our invisible call button, and here it's made much more visible just with tape. Get inside a client's home. It's the last step that really causes a lot of problems for clients in terms of falling. So we can add a contrast by just tacking down a mat to help the person distinguish the last step from the floor. This is black coffee in a white cup and white milk in a black cup. This is the use of color. This was one of the last clients I treated in the clinic, and we had talked about, she had told me how she always lost her phone and she was so frustrated by the whole thing. And we had been talking about contrast, and I suggested that she just try to get a phone cover that was very distinguishable. And she did. She went right out to a dollar store and got herself a bright fluorescent phone cover, came back the next week and said she hadn't lost her phone since. And this is the interior, again, of a assisted living facility where the person was having a lot of difficulty just finding the bathroom within the room. And they took duct tape and they put bright orange duct tape down the side. I can tell we're getting to the end of the lecture because I'm having a hard time talking. Okay, reduce pattern and clutter. So we just looked at this cluttery mess here, and you can improve it by just structuring, particularly high-risk activity like medication management, where you've got it created basically a workstation, and you've got white foam here and black foam here to help her distinguish pills better, and you've got everything labeled very clearly, and you've got a task lamp to boot. I always like to use the refrigerator picture because we don't think about it, but it can be quite a mess, and it can really shut down a person's willingness to create their own lunch if they have to face, or make their own lunch if they have to face this horrible, disorganized, overflowing refrigerator. So we need to think about things like that and structure them for the client. We've added black tape here so that the client can easily see the handles and doesn't spill anything. That brings me to compensatory visual scanning training, which is training that focuses on increasing the width, the speed, and the efficiency of the person's ability to search towards the blind field. And it's done in a very kind of prescribed way where the client is taught to employ a conscious search strategy that's over practiced in order to make it automatic. We use a lot of different activities to do that. Light boards are very, very helpful to do that. So are dual task training strategies. As an intervention for hemianopia, compensatory visual scanning training has the most evidence for its effectiveness when compared to other interventions. That's based on Pollack's Cochrane review in 2019. There have been some good randomized control trials supporting its use there. And the randomized control trials suggest that the training effect is very specific to the task. So emphasizing locating objects in environment isn't going to improve reading and vice versa. Light boards become very helpful when we're doing compensatory visual scanning because they employ gaming principles to increase motivation and practice. They help increase visual anticipation and attention. They help the person employ those strategies automatically because they run on a game mode. But dual task activities with ambulation are also very helpful because they break the habit of shoegazing and staring straight ahead. And they increase the client's confidence in navigating alone in environments. So some examples of that are that we may do scan courses similar to the assessment, but really spread them out over several hallways. We will do things like an activity that I often did with clients was called Find Red, where we'd say, we're going to go down to the front of the building or wherever we were going to go. And I wanted them to point out to me every time they saw red as we move through that environment, to keep their head up and looking for that. Treasure hunts, where we say, okay, we're going to go find the vending area on this floor. And they have to use the signage and other things to cue them. Narrated walking is where they walk and they literally tell you everything they see as they're walking along. So these types of activities. That brings me almost to my last slides. But I wanted to show you, these are the types of activities that we did with Ida. And I wanted to show you her performance before and after the intervention. So I'll start over here with before, and remember that stiff gait, and she looks very uncomfortable and she can't find the doorway. All right, I'm gonna stop that one. This was when she was discharged. The day of discharge, she had had 8 therapy sessions over an 8-week period of time.
In fact, you're walking too fast, Ida.
I was complaining she was walking too fast. Now, to me, that's proof in the pudding that teaching a client how to engage their environment really does improve their performance. Ida went on to resume driving. She was able to do shopping by herself and continue to live independently.
In fact, you're walking too fast, Ida.
Okay. Reading. Not every client is going to be motivated to resume reading, but it can be done. Persons who have hemianopia can improve their speed and accuracy in reading, but it will take a long time to do that. And so we use a kind of a specific approach with pre-reading exercises to help them adapt their perceptual span, then moving them into reading text. And we supplement it with evidence-based reading programs. The read-write program and the DREX are 2 that you can, I included in your handouts, I'm pretty sure I did. And you can find them by searching with the browser. This is very quickly what they look like. The read, write, and the DERM is they use scrolling text that uses the optokinetic nystagmus that occurs when you're looking at scrolling text to bring the eye further to the right so the person can see the other side of it. If you want to read up on it, read on that research. I want to make the point, though, that not everybody is going to resume reading, but everybody needs to be able to acquire print information. That is the goal for all clients. So if they're reading, we want to help them learn strategies that improve their text navigation, like marking and outlining text and e-readers and accessibility features. If they're not going to read at all, we need to introduce them to assistive technology that can help them. Text to speech and vice versa, using software and phone apps, internet connected virtual assistants like Siri and Alexa are just godsends and great for people, and then talking devices. All right, I'm going to get my last slide in here. You may not be able to ask me any questions, though. I had to mention return to driving because persons with hemianopia can return to driving, and often the person with the PCA stroke is the best candidate to return to driving. But driving depends on a lot of factors: government regulations, co-impairments. Dangerous combinations include a hemianopia along with inattention or cognitive impairment, a hemianopia along with hemiplegia, right hemianopia with aphasia. We also have to consider a person's driving history because their stroke isn't going to make them any better at driving. So we need to look at their experience, the number of accidents and citations per year. Some people just shouldn't resume driving. We also need to consider their driving environment because it's very different to drive in a rural area versus a city, or on flat terrain versus hilly terrain, and the extent of their field deficit. They get much better driving outcomes for quadrantanopia and hemianopia that curves with macular sparing and relative field loss. If you want to read on driving, read the citation on Bowers 2016. Alex Bowers gave us a gift all in 2016 by just summarizing driving with hemianopia. Okay, that's the end of the lecture. I'm going to turn on the chat. I've been afraid to turn it on because I knew this lecture was going to take a while. Let's see if I can do it.
Thank you, Mary. All the questions are in the Q&A, I believe.
Okay.
You want to look there? I've got them ready to go for you if you like.
Okay, so we have time to do that.
Oh, and we've got someone raising their hand. So there's a few questions from the same person. One wanting to know a little bit more about writing skills and how they're impacted. Asking about the SCAN course and can it be used in the PCA stroke? And asking about Dynavision and can that be used as part of intervention? And is there any research to support that? I can tell you one at a time.
I know you may have to do one at a time. Can the Dynavision be used as part of intervention? Absolutely. Those light boards are a key part of intervention. Is there a lot of research support? No, there's not. And there has been some research on the Dynavision because it's been around the longest. And I included references to articles when I posted those pictures on that slide, if you want to go and follow those up. But the research is light. But people will tell you that they're very helpful. They're not the single device, but very good. What's the other part, Barbara?
I'm just commenting about can the SCAN course be used?
The SCAN course.
Can it be used? Stroke?
Yes, everything I've shown you is used for persons with hemianopia from PCA stroke or middle cerebral artery stroke. But yes, everything in this lecture is for PCA stroke.
And just asking for a little bit more about writing skills or asking a little bit more about how writing skills might be impacted by a hemianopia.
Well, again, when you put your hand down to write, so let's say I'm left-handed and I have a left hemianopia, when my hand goes down on the piece of paper, I don't see the pen tip. And not being able to see the pen tip is what alters my legibility in my handwriting. So I might not be able to write very clearly, which can be problematic if you have a lot of issues. The key intervention for that is to get the person to look at their pen tip. By tracing exercises are a great way to do it, to teach them that skill by teaching them to, alter their head position or alter position of the paper to improve their handwriting legibility.
Great. All the other comments in the chat are thank you. It was very informative. And someone is asking, will you teach again? Will you reach again? I think they mean teach again soon, a complete course. So I'd love to hear in the evaluation if that's something that people would like us to offer from Central South Regional Stroke. As Mary and I have been talking about, could we do something bigger? So I'd love to hear from you if that's what you'd like to have happen.
Yes, we're working on that.
I think all the questions have been answered. Lots of thank you for a great presentation. So I would like to thank you for this presentation, Dr. Warren. This has been a topic, visual disturbances, perceptual disturbances. I've been asked to find a presenter on this for a long time and haven't been able to do it. So the virtual format has been great for this, and that we're able to bring you from the US to do the presentation. So thank you very much. I'm really pleased that we were able to engage you to teach this really short course. And I would like to hear from people, would they like something more detailed and longer? My suspicion is yes. And I do invite everyone to continue on in this series as we're going to talk about the other symptoms and managing them related to posterior stroke. So thank you once again, Dr. Mary Warren. It was great and really educational for myself.
Okay, well, thanks for having me. I enjoyed it. Okay.
Thanks, everyone.